Hello, hello, hello. My name is Dr. Eseosa.ighodaro. Thanks for coming on stage.
Yeah, happy to learn. Thank you.
Fantastic. My name is Dr. Eseosa.ighodaro, and I am a neurologist and a neuroscientist at Mayo Clinic here in the US. And I love teaching. I love teaching all things neurology. I love teaching to medical students and pre-med students. So what I've been doing is doing these rooms on Clubhouse, trying to give you guys some pearls on how to really hone in on your clinical taking and clinical reasoning skills. So be sure to ping all of your friends, your colleagues, pre-med students, medical students who would find this information very valuable, because I'm teaching you guys high yield information that will be on your step 1, step 2, and step 3 exams. So the fun thing that we're going to do today is I'm going to be walking you through a case. The case chief complaint is a 25-year-old female with abnormal movements. And the fun, exciting thing about this particular room is that I have a whiteboard, and my whiteboard is on my YouTube channel, and you can see my whiteboard in real time with my notes. So it's kind of like we're actually in the hospital setting together in the rounding room, and we're going to talk about this patient. So in order to find my whiteboard, you can do two things. You can go to YouTube and type in Dr. Eseosa.ighodaro, click on my channel, make sure you subscribe, and then you will find you'll see the whiteboard. Or you can go to my Clubhouse bio, look at the first link called Linktree, and that will take you to my YouTube channel as well. So be sure you are streaming this from my YouTube channel, because that is my whiteboard, and that is where all of the notes will be taking place, and you can get real-time information that you could use to after this session, that you could use for taking care of your patients. So I love audience interaction. So I would love for at least 4 more medical students or pre-med students to come up on stage and help me figure out what's going on with this 25-year-old female. I've been doing many rooms like this, and students love it. I'm getting emails from Instagram, from Facebook, from all over saying that I should continue these rooms. So I hope that we have some brave students who can come up and help figure out what's going on with this patient, and make sure you ping all of your friends, your colleagues. This is great high yield content that you guys are receiving from an expert who does this on a day-to-day basis. Again, there's a lot of people coming into the room, so I'll reintroduce myself. My name is Dr. Eseosa.ighodaro. I'm a neurologist and a neuroscientist at Mayo Clinic, and I really love teaching. I love interactive digital teaching. So what I'm doing today is I am going to be walking you through a clinical scenario of a 25-year-old female with abnormal movements. A very creative and interesting and novel thing about this room, it's unique to this room, all this content is being live streamed on my YouTube channel, and I have a whiteboard so that as we're talking, you all can see my notes in real time, and it's like you are here with me and we're in a classroom and we are discussing a patient presentation. So be sure you go to my YouTube channel so you can find my whiteboard, and be sure to ping all of your friends and ping all of your colleagues. Actually, I think you guys are trying to, but we have to figure out how to open this room. So let me ping in one of the founders who can help me open this room so that we can get a large audience participation. So for those of you that are still in the audience, come up on stage, don't be shy. This is the time to get practice on your clinical taking skills in a very fun, non-threatening environment. So who do we have any brave souls that wants to come up? And while I wait for people to come up on stage, we have 2 people. We have a Dr. Simmons, and then we have another gentleman as well. If you guys would like to introduce yourself, go right ahead.
Hey, how's it going? My name is Ben. I'm a first-year internal medicine resident in Rutgers here in North Jersey, and went to medical school at Georgetown in DC. I'm interested in cardiology, but my weak suit is definitely always neuro and doing the neuro exams. I can get the basics, but these tough neuro cases always go up and listening.
Fantastic. Thank you for your introduction. And who else do we have on stage? Feel free to introduce yourself.
Hi, my name is Quad. I'm an MD PhD student at Stanford University. Nice to see you all.
Thank you. Thank you for being on stage. You too will help take care of this 25-year-old female with abnormal movement. And as soon as we get the room open, you'll be able to.
If you could make me the moderator, I can open this room for you.
Oh, thank you so much. Fantastic. So for those of you who are new, who are coming into this room, my name is Dr. Eseosa.ighodaro, and I am a neurologist and a neuroscientist. And be sure you ping all of your friends and your colleagues and people who would find this information very helpful, because this is going to be a very fun, interactive room. And what's so unique about this room is I am live streaming my whiteboard. So if you go to my YouTube channel, Dr. Seosagudaro, you will see that I will be live streaming the notes as we're talking through this case, so that you guys who are in the audience can get real-time information. And I'm trying to simulate the classroom setting, because this is how we do teaching in the hospital setting. We'll do case scenarios, we'll get on the whiteboard, and we're just talking and learning about how to take better patient histories. So if you want to find my YouTube channel, you can do two things. You can go on YouTube, type in Dr. Seosagudaro, and you will find my YouTube channel. You can also go to my Clubhouse bio, and you'll see a website called Linktree. Click, type that into your URL, and that'll take you to my YouTube channel as well. So be sure, it's very important, if you want to get the most out of this interactive session, that you are also streaming it from my YouTube channel. And I love interaction. I love audience interaction or audience participation. So I'm looking for at least 3 more brave people to come up on stage to help me take care of this patient. Looks like we are having people raise their hands. This is phenomenal. People, keep raising your hand, come up on stage so that we can get started. And I will let the next person introduce themselves. And while we're doing introductions, be sure to ping all of your friends. Make sure you're on the YouTube channel and subscribe to my Clubhouse and YouTube so you can continue to follow this phenomenal content. I love teaching. I love it so much. It's like an addiction for me. So I hosted 2 rooms yesterday that were extremely phenomenal. So I'll get on here, and as I have time, I'll host a room. So you really want to follow me, follow Aspiring MDs, and follow my YouTube channel. And I will let the next person introduce themselves. We need 2 more people, 2 more brave people to come up on stage, and make sure you're pinging your friends. And next person, please introduce yourself. Lima?
Hi, Islam. I am the 3rd-year medical student from Saudi Arabia.
Fantastic. Thank you for introducing yourself. We need 2 more brave souls to come up on stage. Who's going to come and help us take care of this 25-year-old female with abnormal movements? This is the time to get real-time, interactive, expert feedback on your presentation in a fun, non-threatening environment. So who do we have? Do we have any brave souls that'll come up and help take care of our patient? Or if the current stage members want to ping other people to the stage, go right ahead. Any brave people? All we need is 2 more people. This is the time to get your practice in. There's no grades. This doesn't get reported back to anybody. This is your time to learn. Ooh, fantastic. Looks like we have another person coming up on stage. Oh, thank you. We have been in rooms together. Thanks for being on stage, Doctor. Would you like to introduce yourself?
Are you talking to me?
Yes, yeah.
Hi, everyone. My name is I'm a pulmonary critical care and lifestyle medicine physician. So I just joined the stage. Really, I'm not going to do a lot of talking in the sense that it shouldn't be me working through the case. It should be the folks in training, but I'm happy to help out, help guide.
I appreciate it. Thank you. Thank you so much for that. And please, ping your friends, ping anyone else who would find this information very helpful. Make sure you're on the YouTube channel and come up on stage. This is a fun way to learn. This is a safe environment. And what I have learned in training students is everyone is very nervous when it comes to neurology, because unlike any other field, the neuro exam is very important for us. And the way we think is different from other specialties. So we think in a way that requires us to localize, and we're always figuring out how do we localize these symptoms and these findings. So these are the type of things that I will be helping you guys learn in this room. So feel free to come up on stage. We are looking for 2 more brave souls to come up on stage and to help take care of this patient, 25-year-old female with abnormal body movements. Any brave souls? 2 more people so we can get started. For those of you who are new to the room, make sure you go to my YouTube channel. I'm streaming my whiteboard notes so that you can get full information from this session. Well, we can go ahead and get started. And if anyone wants to come up on stage and answer questions or participate, you're more than welcome to. I will leave the raise hand function on. So what I will do, now that we are here, I want everyone on stage to pretend that you are, except for the senior doctors, pretend that you are an intern. And it's July 1st. It's a very extremely busy service. You're on your neurology service, and the senior resident wants you to go see this 25-year-old female with abnormal body movements in the emergency room. It's very busy, and she wants you to see this patient on your own because you're a doctor now. It's July 1st. So how we're going to do this is I'm going to be the patient, and I want you guys to pretend like you, in 30 minutes, I'm giving you guys 30 minutes, and I want you to ask all the pertinent questions you need to ask. We're just going to focus on the history taking. We're not going to focus on the vitals or physical exam or labs or imaging, because the history taking is the most important anytime you talk to a patient. So we're going to focus today on the history of the history taking. We'll give you guys 30 minutes, and it can be a joint effort. And at the end of 30 minutes, you will present to me, because then I will then become the consultant, and you'll present to me, and we'll talk about the presentation. We'll talk about the key points. And then at the end, I'll give a 5-minute rundown of how to ask how to ask questions given what the diagnosis is in this person. Does that make sense?
Yep, that makes sense.
Should we ask you?
Let's get some more students up to this. I mean, we'll start, but I see some more people trickling in. Definitely come up and help us out here on stage. We're trying to figure out this tough neuro case.
Feel free to ping and raise your hand. Okay, so now let me get my acting face on. We have 30 minutes on the clock. It is 9 o'clock, at least here where I'm at. So in 30 minutes, I hope you guys have diagnosed me. Okay, action.
Okay, so what brings you into the hospital today?
Oh, wait, who are you?
I'm sorry. Hey, I'm Dr. Simmons, one of the interns here at the hospital. I was asked by one of the neurology seniors to come. What brings you in today?
Oh, well, my partner was worried because I was just having some, it's really hard for me to remember. I guess I was just having some weird movements, and I was not looking good. So he suggested that I come in.
And can you describe these movements to me?
No, I don't. I can't remember really. I'm still kind of it's hard for me to remember what all the things that have really happened.
That's fair. Can you tell me when everything started or when your partner tells you it first started?
Well, I was eating breakfast and then he said all of a sudden that my eyes were looking funny and that I was like foaming at the mouth and that I was just shaking.
If anyone wants to hop in, go ahead and hop in. But so, all right, go for it. And have you had this before?
I have not.
Are you in any pain right now?
Should I be? No.
Okay.
So when you're saying that you don't remember much, do you remember the event at all? Do you remember starting?
What I do remember is that when the symptoms came on, like a couple minutes before, I felt like very nauseous.
And when was this?
In the morning.
Which day?
I don't even know what today is. I don't know. I just know that I woke up, was eating cereal. I felt nauseous. And then I guess I had this symptom.
So it's today, this morning you're talking about?
Yeah.
Got it. And have you had any events, anything different you want to talk about that happened last week, a month ago? Did you travel? Did you hit your head? Did anything happen?
No, just, a normal day. Nothing out of the ordinary.
Did you have any episodes of vomiting, or did you vomit at all, or was it just a nausea?
No, I didn't vomit. It was just a nausea.
And then have you noticed any changes in your bowel movements leading up to today, either diarrhea, constipation?
No.
Okay. Any chance you might be pregnant?
Oh, I hope not. But I guess there's always a possibility.
For sure. Thanks for sharing that. And can you tell us about your medical history? Have you had any major surgeries, hospitalization, any diseases in the past?
No, I'm pretty healthy.
Any meds?
Nope.
Allergies?
Nope.
Okay, so you're not taking anything.
No, I'm pretty healthy.
Gotcha.
I run marathons.
Any recent cold or flu or runny nose symptoms before, like prior to this week?
No.
And what did you eat this morning as for breakfast?
Oh, what did I eat? Cereal, Cheerios. Cheerio. Get it? You guys are a tough crowd.
And any history of any herpes viruses that you know of, like either cold sores or genital herpes? Just kind of thinking of like different viral encephalitis type of picture.
No.
All right, can you tell us a little bit about your family? Are your parents still with us today?
Yeah, they're still alive. Go ahead.
Do they have any medical conditions?
They have, so my great-great-grandma had high blood pressure, and then my grandpa had a stroke, and then I think my second cousin may have maybe had what do you call it? The sugars, and then my mom has high blood pressure, and then my sister has high blood pressure too. Oh, I forgot my great auntie has, what do you call it? The sugars.
Diabetes?
Yeah.
Gotcha.
Is there any similar episode in your family?
Nope. I guess I'm the lucky one.
Can I make a suggestion?
Yep.
So one of the things that I like to do when I'm talking to a patient is after they have told me their story, I ask them to be patient and I say, hey, I just want to repeat back my understanding. So if I'm misunderstanding something, you can jump in. And then that way everyone is sort of on the same page, because we all hear things the way that we want to hear them, and that may not actually be what the patient is. Depending on the patient's cultural background, they may describe something in a way that you interpret in one way, having been trained in Western medicine, that the person themselves may mean something else. So I always like to repeat back what a patient says to me, or I understand. And then the opposite is true. When I'm educating the patient, I ask them to repeat back what I have said, so that I know that they're on the same page as me when it comes to discharge instructions, for example. So if one of you guys is willing to do that, that would be ideal, to just kind of sum up your understanding of the case.
Sure. So, hey, I just want to tell you what we heard, and I'll summarize it. And if I'm getting anything wrong, or if you're going to tell me something extra, just let me know. So you woke up this morning on just another day, and you were eating breakfast, Cheerios, and that's when you started to have some kind of abnormal movement. You don't remember what happened, but your partner told you about that, and that's why you're here. Does this sound right?
Yeah.
Mm-hmm. And then you have no other medical conditions. You're not taking any medicine, and you are so far so healthy.
Mm-hmm.
Sounds good.
And the only other symptom that was associated with it was your nausea that you had right before you started, or right before your partner said he started having these movements.
Yeah, I had the nausea and just like a weird smell sensation. Like, I don't know, like things were just had this like metallic type smell.
And do you know what your partner said about your movements? What happened exactly? What did you move?
Yeah, he said I was moving, like just thrashing everywhere. Like my arms and my legs were just all over the place.
Great. And are we able to do like a physical exam, neural exam at this point?
Yeah, we can, but for this room, I just really wanted to focus on the history taking, because I want to make sure that the audience and you guys understand what is the pertinent information to get from a patient that presents with these symptoms.
Anyone have any other questions about associated symptoms? Anything that partner might have noticed, since she was, by her word, sort of out of it? What happened?
Yeah. So is your partner here with us?
He is. Would you like to talk to him?
If possible, that would be great.
Okay. Hello? Hey, who are you? Oh, I'm very worried. Like she was fine this morning, and now, I just saw her just like shaking all over, and I'm like, that's not normal. So I called EMS and they brought her here. What's going on?
That's what we're trying to figure out as well. So hopefully we can figure this out together. Now, can you describe to us a little bit of what exactly the movements were that you saw? For instance, I'll give you some examples and you can explain from there. Did you see anything that looked like she was either biting her tongue or biting her lip, or eyes rolling to the back of her head?
Yeah, exactly. It's like you're reading my mind. How do you know all that?
Well, when patients come in with concerning symptoms, we like to try and put them in different categories. So I'm just asking questions from a certain category that may help us point us in one direction or another.
Yeah, 1 minute she's eating Cheerios, and then the next minute, sorry, my voice is changing. The next minute, she said that she was having like a very like intense smell, and things smelled like metal, which was weird. And then she was complaining of like having really bad nausea. I was like, you better not be pregnant. And then she started shaking. I was like, holy crap, that's not normal.
Yeah, and then how long did that happen last for?
It lasted for about a minute.
Did she lose consciousness? Do you remember? Was she conscious the whole time?
No, she definitely lost. Like when I would say, hey, Sally, she did not respond to me at all. She just kept shaking and, her head. Oh, I forgot. Yeah, her head was turning. It was weird. Like it's right out of a horror movie. You know what I'm saying? Like when those people that are like exorcist or whatever, like that's what she looked like. Like that was scary, man.
And once again, just to go over the family history one more time, you and your partner both said that there was no family history of seizures that you know of or any type of seizure disorders. Have you heard that word?
What's a seizure? That sounds concerning.
Yeah, I mean, seizure is something that happens to somebody that presents with symptoms, but they present similarly to some of the things that you're describing. But there's many different types of seizures. One very specific type of seizure has this movement where patients are turning towards one side and are having this shaking like movement. So we're just trying to figure out, and a lot of types of seizures do have some influence on family history. So that's just where we're trying to figure out.
Oh, okay. I don't. This is her partner talking. She never told me she had a family history of seizures, but I really don't. We just started dating maybe like 6 months ago, and so I haven't gotten to like the family health part yet.
And do you drink?
Me, the boyfriend? Do I drink?
The patient.
Oh, okay. Let me switch. The patient? No, I don't drink. Nope.
Okay, and then do you see your primary care?
No, not really. I'm 25 and I only go if I have to, and I'm pretty much healthy.
Got it. Thank you. Yeah, I think I'm leaning towards seizure, secondary diabetes, and yeah, that's my thinking at this moment.
So I just want to jump in here. When you were asked about alcohol history, she paused a little bit and said, no, kind of not really. So I always want people to give me very specific answers. So because people can mean very different things. I'll have a patient tell me they don't drink a lot. And when I ask them what is not a lot, like give me a specific amount, they'll tell me I drink a pint and a 6-pack a day. Because for them, that's not a lot. So and I don't say that in a judgmental way, but specifics are important. The other thing to remember is you've just asked about alcohol. Go ahead and ask all the other social history questions at that time, right? So ask about drugs, ask about smoking. And that includes pot. Ask about any sort of social factors that could be potentially influencing this. Has she been under a lot of stress lately? Is there anything else going on? So that was one comment I wanted to make. The other comment I wanted to make is the patient has said, and the patient's partner has said that she was thrashing around quite a bit. She was sitting and eating cereal and then started thrashing. Did she fall? Did she hit her head? These would be things that we want to know, not necessarily for the initial diagnosis, but for any potential complications that can occur from whatever this diagnosis is.
For sure, that's really, really helpful. So what was the patient's name again?
My name is Sally.
Got it. So Sally, I'm going to ask you some personal questions, and everything we're talking about here is going to be confidential between us, unless there's something we need to do to somebody. So is that okay?
Yeah, thanks.
Yeah, so you said you don't drink, but I want to ask you more questions. Do you smoke?
Smoke like what?
Cigarettes?
Nope, I don't smoke cigarettes.
What about any drugs, illicit drugs?
I like marijuana.
Okay. And how often do you smoke?
Like socially.
Got it. And how's your sexual life? Do you have any concerns or questions? Anything you worry about?
Ask my boyfriend. He's right there.
I think I would have done this with him out of the room. So I'll correct that about this process. Ben, you want to ask some extra personal history, sensitive ones?
Well, so I'd also ask, she said socially, what does that mean to her? Is she going out every night and drinking and smoking? Does she do it on the weekend? So again, specific numbers are important. So what I always tell a patient is, what does that mean to you? Because that answer can vary between patients. And so I like to get a specific actual quantum. If you had to quantify the number of joints you smoke or the number of drinks you have in an average week, what would that be?
For sure, thank you.
So just back to the alcohol thing. When was the last time you had an alcoholic beverage?
Oh, my memory is, I don't know. I'm just so tired. My boy, okay. My boyfriend, what was the last time I drank? You drank like maybe a month ago.
Okay. Thank you. And now, do you feel comfortable answering sexual history questions with your boyfriend in the room?
I guess. What is I mean, what does that got to do with abnormal movements? That's kind of weird.
We just want to make sure we get a full history that includes everything. What in the back of my mind, what I'm thinking is just making sure we rule out like STI causes like encephalitis that could lead to possible. Seizure is still high on the differential, but I'm still thinking of different infectious causes of seizures. So like anything that could cause some encephalitis pictures. So it's still HIV, syphilis, those things are still at the back of my mind. So that's why I would push for STI testing. But as far as how I present that to the patient, I probably would, in real life, I probably actually would have just said, I just want to have a few words with you without anybody else in the room. Is that okay? And then gone from there instead of specifically saying that I'm going to be asking sexual history questions. But yeah, Clubhouse puts you on the spot. But that's where my mind was going.
Better not have no STIs, because if I do, ooh, hell's about to break loose.
And we don't suspect that you do, but we just need to make sure that we're ruling all the things that we think are less likely out as well, just so we can narrow our focus on what we think it might be.
Okay. Well, I don't have nothing. He better not have nothing, or it's about to be something up in here. I'm gonna pause. So I'm gonna reset the room. Hi, everyone. My name is Dr. Eseosa.ighodaro. I'm a neurologist and a neuroscientist at Mayo Clinic. I do a lot of virtual teaching online. I love teaching. So what I've been doing here on Clubhouse is doing frequent clinical sessions that focus on patient history taking. Because what I've noticed and seen, starting out in medical students, that sometimes they are not able to ask questions in a very systematic way. So I want to help teach you all how to ask questions in a very systematic way that is focused, and you get the information that you need so that when you present to your senior resident you're attending, you have all the necessary information to present. A really phenomenal thing about this specific room is that I am recreating the classroom. So not only are we talking on Clubhouse, I'm also taking notes on my YouTube channel for the whiteboard. So if you want to see my whiteboard notes based on the questions that the participants on stage have been asking, you can go to my YouTube channel. My YouTube channel is Dr. Eseosa.ighodaro. You can also go to my Clubhouse bio, and then you'll go to Linktree, and that will take you to all my different social media platforms, and you can find the link there. So be sure to make sure you're following and listening and streaming the YouTube channel so that you're getting the full content of this lecture series. And the people on stage are doing a phenomenal job. So kudos to you all. There's any other people that are on stage that are in the audience who want to come help answer questions or ask questions, feel free. The floor is open, and we have about 10 more minutes to ask any other questions that it will be relevant to this 25-year-old female with abnormal body movements. And so with that,
I have a general question and then a comment. And this is because my training was years and years and years ago, when, back when Palm Pilots were a thing. But I was old school and it did not use a Palm Pilot. So I'm curious, do medical student residents nowadays, even to this day, if I'm seeing a patient who's very complicated, I always have a notepad and a pen that I take notes on. But here's the reason I'm asking that question. In some ways, it's easier when you've got a piece of paper. I actually had created that I used for all of my PPs. I couldn't forget something because there was an entire list of things I go through in order to examine my patient and to get everything down appropriately. So I don't know if that's something that you guys can do. I don't know if you guys are using app, if that's part of an app, but to me, that's a valuable way to do it. It's also very cool because until you get to hearing long, complex histories and then an hour later sitting down to write your note and documenting, it's very helpful to have things written down. Be cognizant when you're writing things down, though, of how that is interpreted to the patient. So just let them know, hey, I'm going to be taking notes so that I can make sure that I accurately portray what we're talking about today. And the reason I say that is I have noticed that occasionally, if I'm hearing a history, I don't necessarily write down the stuff about the history because now I'm very well versed in being able to go talk to 5 different patients and still get their histories correct. But I always make it a point to write down the social history. And it's recently occurred to me that the patient may interpret that as, oh, that's something really meaningful. The doctor just chose to write that down. And they may see that as a judgment of them. So just make sure that they understand that as you're jotting things down periodically, it's not an assessment of what is important or what is not important. It's simply a matter of this is an actual concrete fact that I don't want to forget. Right? It's oftentimes easier to understand the narrative that the patient tells you, but you may forget that they're telling you that they smoked a half a pack a day for 20 years. So just, those are some things to think about. Like I said, I had a very clear document that said, chief complaint, HPI. I never put in the stuff that, in hindsight, I probably should have. I forget what it's called. What is it? The alphabet thing, the LMNO. I'm sorry.
QRS.
I don't remember what. Because I traditionally ask all of those questions, and that was going to be point number 2. Is you guys have done a phenomenal job with the history, but it's important even when the patient can't tell you specifics about the case because they themselves don't remember. Here we have the fortune of having the partner there, so it's important to ask them, hey, were you able to do anything to make it better? Did anything happen to make it worse? What ultimately stopped it? Was it something specific or did it stop on its own? Right? All of these are going to help you distinguish and change and adjust your differential diagnosis.
And I love how you brought that up because yesterday I did a room that focused specifically on a systematic approach to taking a patient history. And that was about an hour and a half long room. And that live stream is actually recorded on my YouTube channel. So for those who want to go watch that, you can, and you'll see the whiteboard. And we go through how to take a patient history in a very systematic way so that you're not forgetting the review systems or the allergies or their surgical social history. So it's one approach. It's an approach that I use. And when I started out in intern year, a lot of the feedback I got from my attendings were, you ask really good, thorough histories. And it's because I develop a system to where I do the same key things every time. And I, as I move along in my career, I can kind of tweak that basic framework, but I always go back to that framework so that I don't miss anything. So be sure to check that video out. It was posted yesterday, and that will give you one example of how to organize your history taking. But that's a phenomenal point.
Ben, I was just going to say quickly, I'm an ER doc in San Francisco, so I ask people uncomfortable questions within minutes of meeting them all the time. I think Ben and Kwat, you guys are doing great. It is hard to ask these questions, especially starting out, especially personal social questions when you're literally a stranger to them. The one thing I was going to say is, especially when if they're there for vaginal discharge, I think they're not going to be surprised that you're going to take a sexual history. But when it's something that, might to them might not be apparent that it's relevant, I will often kind of let them know that I'm trying to be thorough. So, this patient's obviously very concerned about what happened to her and very worried and probably very scared. And so I will, like others said, kick everybody else out of the room and then just say, hey, I want to be thorough because I'm really, show your own concern and your own compassion. I want to be thorough. I'm really concerned about you and your symptoms. I'm really glad you came to the ER today. And so I just want to ask you a bunch of questions just to make sure I'm not missing anything. And that's the way I will kind of start these conversations, to make it feel a little less awkward for me sometimes. Because obviously, if this is a seizure, usually often I won't ask about sexual history. And so being thorough and just showing your concern is a nice way to make that bridge and show the patient that you're really trying to do a good job of being a doctor.
Phenomenal.
Appreciate it.
Yeah, thank you. Thank you for that pearl. These are such phenomenal pearls, everyone. So for those of you on stage, for those of you that are in the audience, these are, you're getting the opportunity to get phenomenal pearls from physicians and attending. So I hope that you're taking notes. I hope that you're following the live stream with the notes, the notes that I'm taking as well. And be sure to ping your friends, your colleagues, and be sure to follow my Clubhouse and also follow YouTube, because I will continue to do these sessions, because what I want is for you guys to be able to take the knowledge. You guys know the knowledge. I don't have to teach you that. You guys know how to study. It's about taking that knowledge and applying it to the clinical scenario in the hospital or in the office. And so that's what I want to help you all do, because that's the most exciting part for me. That's why I am a physician, is being able to interact with patients. And you want to do it in an efficient, effective manner with compassion, so that you get, you can take care of your patient. So we have about, I'll give us 5 minutes left. If there's any other questions you guys want to ask Sally and her partner before the consultant comes in.
I do want to ask about the fall or any kind of injury during the movement. I want to ask the partner about that.
Yeah, this is the partner speaking. Yeah, she did fall. Like, she was eating cereal and then she started shaking, and I wasn't able to catch her in time, so she fell. And it was a hard fall too. We have like, what do you call it, marble floors or whatnot, and she hit her head pretty bad.
And where is she hit? What part of the head?
I think she hit the back of her head.
Is that when she lost consciousness? When she fell?
Well, she was already not responding to me when she started having the seizures. So she started having the seizures, then she fell out of the chair, and it's like everything just happened so quickly. And I was just like, yo, I don't know what's going on.
And again, just to review, she's not on any medication. She's not taking birth control, anything like ibuprofen or no medication that you're aware of?
No, not really.
What are you thinking with that?
What?
Just like, what were you thinking as far as narrowing the differential with the birth control question?
Nauseous. She said she wasn't really sure that she might have been pregnant. So I just wanted to review.
Oh, that's great. That's great. No, I like to ask. I love thinking through people's thought processes. So I don't immediately know what the question is for, and that's why sometimes after I ask the question, I also say why I said the question. Sometimes it gets annoying, working through that.
Yeah, but she said she's there's no chance she can be pregnant, but she's also not on birth control or anything. So.
And I'll ask one more question. How's your sleep been lately?
Been fine. like any other college student, you know.
And okay, what do you mean by fine? And how long have you been sleeping every night?
Maybe 6 hours, you know, a day, which is typical for me.
So can I suggest a couple more questions that haven't been asked yet?
Please.
So, well, or let me ask you a question. You guys are down the path of seizure. Whether that's right or wrong is irrelevant at this point. If you're thinking seizures, what are some other questions that we typically ask that aren't necessarily specific only to seizure? We can sometimes see this in syncopal events as well. But there's a couple other symptoms that you might want to ask about, or signs, I should say, that she might not have noticed until she came out of it, that her partner potentially would have noticed.
We want to ask about what happened before the seizure, during the seizure, and after the seizure. I think Ben did that, and we wanted to ask about any kind of toxic cost. So I think we can rule that out because she's not taking anything, and I don't think she's doing anything illicit. Maybe I'm wrong there. And we also need to think about the psychogenic cause of this. I don't think we're asking enough of that. So is that what it is?
Well, no, I'm specifically referring to incontinence.
Oh, gotcha.
Right, that can often help us. This is for another discussion, distinguishing seizures from pseudo seizures. And there's no indication that this woman has just randomly decided to have a pseudo seizure while eating cereal today. But certainly, and that's not to say that people don't have urine leakage during a pseudo seizure, but it is a question that we want to ask, not necessarily because, they did not have urine incontinence, therefore it could not have been a seizure. But if they did, it does point to a loss of functions that we have some control over, right? So that's an important question to ask. If you're going down the route of seizure, and this is actually why I thought the student was asking about oral contraceptives, is another question I always want to ask is there any reason that this person might have had a hypoxic event, right? Hypoxia can lead to seizures. So if she's on oral contraceptives, did she have a PE? I mean, we haven't asked a thorough history on that aspect yet, but, did the partner notice that her lips had turned blue?
Makes sense.
Maybe also dehydration or sleep deprivation.
Phenomenal. This is a phenomenal conversation. So we're at the end of the 30 minutes. Great job, everybody. So now we are going to talk about the differential. So if you guys haven't tuned in already, make sure you go to the YouTube channel, because I'm going to be writing a lot of things on the whiteboard now about the differential. So what's on your differential for this person? What do you think is going on based on what I told you guys?
For me, the downward one is generalized seizure.
Good.
And I'm linking that with the family history of diabetes. And I'm also thinking about any kind of trauma. I'm worried about what's happening within the head.
Good. What else?
I'm definitely thinking all the infectious causes. I want like meningitis, HIV encephalitis, HSV encephalitis, those types of things. Probably not neurosyphilis, just she's probably younger, so it's taking a while for that to be laid for that long. But just infectious causes. Yeah,
so I think that's great, but let's take a step back. So before we get into the etiology, because you're getting at the etiology of what could be causing these, seizures. Are we sure that this was a seizure? And if not, what else is on our differential that we should make sure it's not, or at least think through it? So I guess the bigger question is, what's on the differential for a patient, 25-year-old patient that comes in with abnormal movements?
The patient and her partner were talking about that metallic smell.
Mm-hmm.
So I'm thinking maybe GI. I'm thinking. I'm not really quite sure, but it's definitely
Okay.
part of my process.
Okay. That I can see why you would want to add that. And the differential for, I guess what I'm trying to get at is I don't want you guys to prematurely close, because that's how we miss things. And sounds like you guys are thinking seizures, but we want to make sure we have at least thought through some of the other differential diagnosis that can be seen with seizures. So some of the things.
Sorry.
Go ahead.
Like, the doctor, quick care doc, Dr. Nayak was it? Kids, I was talking about pseudo seizure. That's definitely on the differential. I think.
Yep.
Other like neurologic disorders like MS could be on the differential. I think like what else? I don't know. I probably would add MS.
Okay. So
Guys, do people ever shake when they lose consciousness?
Yes.
I'm sorry, sir. Repeat that because I talked right over you.
Oh, I was just saying, I was thinking of other things to add to the differential that weren't directly seizure etiologies, and I was just thinking like MS, even though that's less likely, but just to make it broader differential, just because of her age. And also on that vein, I would put like lupus, because that can be anything. So.
No, I meant Dr. Walker.
Oh, I'm sorry.
Oh, I was just asking the room if people ever shake when they lose consciousness.
Which is funny because that's literally what I talked over you. So, the question is, if someone passes out, if they have a syncopal event, can they have seizure-like activity?
Yes, maybe.
Yeah, they definitely can. I think that's probably one of the most common things I see in the ER is people who the boyfriend, the partner says, "Oh my gosh, my girlfriend had a seizure," but it was actually a syncopal episode, and almost always it's in the setting of somebody having something that could trigger syncope. There was a good study that came out last year that I've started using. Essentially, if they have less than 10 beats of movement, it's likely, obviously with the rest of history taken too, less than 10 beats of movement was highly predictive of it being syncope, because typically you might have a few little jerks as your brain is not getting perfused, and then more than 20 was highly predictive of seizure. So that's a fun little question I've started asking, because it does seem to be a pretty good test if somebody can say, "Oh yeah, it was definitely." She shook more than 20 times, much more likely to be seizure than syncope.
Nice, that's a good one. So I think in this case, she had like 5 minutes of this jerky motion and had foaming at the mouth in addition. So I think that puts those other syncopal causes lower on the differential. But I think she said 1 minute, right? It wasn't 1 minute, not 5.
Yeah, it was 1 minute.
Not 5.
I think in this patient that it could very well be a seizure. Because you said there was a metallic smell that could very much present an aura, and the patient did, her head was turning, right? Like her head was shifting, like a horror movie, like that motion was described. So that could be like a focal sign. So in this patient, I'm thinking that she might actually have a focal to generalized seizure.
So you mentioned aura, which I think is important because there's one, where else do we see auras? It's a little bit of a rare thing that you'll see this association, but what else causes auras that might actually manifest with a seizure?
A migraine?
Yeah.
Migraine might present an aura.
It's not a common aura for a migraine, but it is in the differential. So we do want to think about that. One of the key things that from my practice, when you're in the ER, your job is to very rapidly assess a patient to the best of your ability without missing anything major. But once a patient, let's say for argument's sake, let's say this patient ends up getting admitted to the hospital. We have a tendency to just want to sort of fix the problem, but we don't necessarily always focus on why did the problem occur. right? And that's really what we always need to get at, because if you only fix the, so for example, someone comes in DKA, great, you fix the DKA, they're no longer in DKA. But if you actually talk to them about their diabetes control. So in the same way, when we're thinking about these issues, it's important that we not only think about what does the patient in front of us actually have, but we also want to think about, and you guys are doing that, what are the things that might have caused that to happen, and what can we prevent in the future?
Phenomenal, all phenomenal discussions, and you guys are doing a phenomenal job with the assistance of the physicians on the stage and thinking through this very tough case. As I know from a medical student perspective, people are afraid of neurology, and I don't want you guys to be afraid. I want you guys to be excited and have a framework to use when you approach patients with neurological symptoms. So now that we have the differential diagnosis, a key takeaway is to not anchor. Yeah, we think that she has seizures, but what else could present like seizures? So as everyone mentioned, syncopal episodes, basically it's called convulsive syncope that presents like a seizure, but it's not a seizure. And then also pseudo seizures, which is a diagnosis of exclusion. So that's not even on my differential until I've ruled out everything else. So now that we think that her leading diagnosis is generalized seizures complicated by trauma that started probably with a focal oral onset. So after seizure, the next question that your attending will be asking you, especially if you're on the neurology service, is, okay, so she's having seizures. So why is a 25-year-old female who's otherwise healthy having seizures? So that gets us into the etiology. So once you think, okay, most likely these are seizures, now we get into the etiology. So that is going to be my next whiteboard, is what are some of the etiologies for seizures, and is there a mnemonic that anyone uses to help tease out what the etiologies of seizures can be? So that was a hint.
I'm not sure about the mnemonic, but I always follow the vitamin D structure of differentials. So for every presented complaint, I always check if there's a vascular, infectious, traumatic, autoimmune, metabolic, neoplastic, or other cause that might be causing the seizure. So I follow vitamin D. So for seizures, I guess the vascular would be subarachnoid bleeding or stroke or an AVM. For infection, it could be since she's focal, it could be a encephalitis, it could be an abscess, it could be neuropsychosis if she has a prior history of eating uncooked pork. She has trauma, but I don't think the trauma might be the cause for seizures, because she was having the seizure activity starting before she fell. For autoimmune, it could be MS or lupus, perhaps. For metabolic, it could be anything from DKA, hypo or hypoglycemia, electrolyte abnormalities, hyperthyroidism. But in this case, since she did present with a focal sign in the beginning, something metabolic is less likely, since her cause is probably something more focal. Neoplastic, she could be a tumor or metastasis, and for others could be like hypoxia or drugs or intoxications.
Do you want to go into neurology? Because I really want to recruit you to become a neurologist if you haven't chosen your specialty. No pressure.
I'm a medical student. I'm in my final year, and I guess I am hoping to be a neurologist one day.
Oh, that's so exciting. I could tell. I was like, that's exciting. Okay, good. Awesome. You can hit me up offline if you want to talk more about neurology. It's phenomenal.
Thank you so much.
Yeah, no problem. Phenomenal. You are right. There's many ways to keep in your head what the mnemonic is, or how to tease out what the etiology is of the seizures. But when you're asking the questions and you think seizure is high on differential, what you want to start thinking of while you're asking the patient questions is, okay, what is the etiology? So one mnemonic that I use that I love is vitamins. And so if you go to my YouTube channel on my whiteboard, you see that I wrote out vitamins, and that helps me keep the etiologies in line. So as he mentioned, at least in this mnemonic, V is vascular. You know, could she have had a stroke and now she's bleeding in her brain and the brain doesn't like blood. It causes it to be irritated. Could it be a stroke, infection? You guys talked about, could it be, you know, meningitis? Could it be that cyst?
Neurocysticosis.
Thank you, neurocysticosis. Could it be an encephalitis, HSV encephalitis? So yes, infection is a major cause of seizures. Trauma. T is for trauma in the vitamins mnemonic. A is for autoimmune. M is for metabolic. You know, hyperglycemia both can cause seizures. Hyponatremia is known to really cause seizures as well. And then another one is idiopathic, and that's really a diagnosis of exclusion. Once we look at all the secondary causes, if we can't figure out why it is, then we say, okay, it's idiopathic. And neoplasms is a big one as well. So here's a fun pearl for you all, is the most common cause of seizures in individuals greater than 18 is what?
Toxic.
No.
Stroke.
Yes.
Stroke.
Yep, stroke. Stroke is the leading cause of seizures in individuals greater than 18. Now, what is the leading cause of seizures in people? Actually, I don't want to tell you that. I was going to say people less than 18, but now I'm not sure, so I don't want to tell you something wrong. So, yes, stroke is the leading cause of seizures in people greater than 18. Here's a fun fact. What's the leading cause of seizures worldwide?
I'd have to guess infection.
Yes. Yes. Yep. Yep.
In the US, it's probably epilepsy.
So what is worldwide, what type of infection? You guys mentioned it earlier. Neurocysticosis. Yes, that is the leading cause of seizures worldwide. So just fun facts. So the big takeaway from this is we think she has seizures. If you think seizures on a differential, you want to go through a mnemonic, or at least go through the etiologies. So now we are going to go into, based upon that conversation, what are some testing that you guys would want to do in this individual to tease out why she's having these seizures?
Maybe we could do an MRI to rule out the structural causes of the seizure.
Okay.
For the seizure itself, maybe we could check an EEG to see the morphology.
Okay. So let's start with labs. So she's in the ED. You've done taking the history. You think that she's having seizures. You work through the etiologies. So what are some labs that we could run that would help us with our etiology for seizures?
CBC.
Yep.
Electrolytes like sodium, potassium.
Absolutely.
Sugar to check for possible hypo or hypoglycemia. Maybe you could also check for other stuff on the metabolic panel, like renal function tests or liver function tests. Maybe a blood gas if needed, and maybe check for an AED level, anti-epileptic drug level, in case she was a previous epileptic who took anti-seizure drugs.
Yeah, very good. Yeah, very good. What else would you get? But now think about her case, and we're just going to focus on labs. 25-year-old female.
A pregnancy test?
Yes, a lot of students always miss that. So any age, any female in the reproductive age, you always want to get a pregnancy test. That will show up a lot on your board exams. So always keep that in the back of your mind. What else would you get? And the patient who she's a 25-year-old female, she has seizures. What else? What other labs?
So we talked about CBC, Chem7, and resistant glucose as part of that. Should we also get the EVT check just to rule that out? What do you guys think?
What do you guys think?
Well, I'm thinking because you said the number one cause is stroke,
Mm-hmm.
and because of this age group, I do want to rule that out if possible.
Okay, so let's focus on labs first, because I want to teach you guys how to think through things in a very systematic way. So how I like to think through things is once I, get the information, and we didn't talk about vitals or physical exams, we can do that another time. Then I think, okay, what are all the labs I want? And then what's the imaging I want? So we're still on the lab. So is that all the labs you want? You want CBC, CMP, glucose? Okay. What?
You want to typically say lactic acid. I'm going to jump in here just really quickly about an ABG. Just remember two things. Typically, the ABG is going to have to be done by the respiratory therapist. That's not a reason to not get the ABG, but your ER physician is likely not going to have time to do that. And then the second thing is, if you're looking for hypoxia, what's an indicator in the room that doesn't require us to effectively stab the person?
An oximeter?
Exactly. So if their SATs are 97%, ABGs are painful. I make mistake of letting a medical student do one on me because I've got a visible radial artery. It is very painful. So if I can avoid and I'm a pulmonologist, so I love ABGs, but if I can avoid putting a patient through that, then that's a really good thing for them, right? So if you have a way of getting that information in another way, we should try to do that.
And the toxic screens, just through toxic radiology.
Okay, what kind of toxic screens?
I don't know. All the drugs.
All the drugs. I love it.
All the drugs, all the metals.
Let's
They make new drugs too quickly for the screen.
Let's be specific. Who wants to help? I love this idea of all the drugs, because you're right. I would definitely get drug testing on her, but when you're on, when you're in the computer, all the drugs doesn't come up as an order. So what specific orders are you going to be putting in?
Cocaine, amphetamines, alcohol.
Yep. Okay. So that's also known as a urine drug screen.
Oh yeah.
Yep. So UDS, and you can get alcohol levels. What?
Bupropion. I just remember bupropion.
Is she on bupropion?
Nope.
So then would you want to get bupropion level?
Probably not.
Yeah. So we want to do. Why would you want to get opioids? Well, I guess that's in the UDS. Yeah, so it'll be in the UDS. So things being common, you could get an alcohol, you could get at least here in the US in the hospital, if I'm getting an alcohol level, I'm also getting an aspirin level and a Tylenol level, just in case, to make sure that most things being common. Okay, any other testing you guys want to do? So if you look at my whiteboard, we have CBC, CMP, glucose, LFTs, pregnancy tests, alcohol levels, Tylenol, aspirin, and UDS. Anything else?
Lactic acid.
Okay.
Kimberly, I love that answer. That is a very ER answer. If you get a lactate within the first, if the patient comes right in after their seizure and you get a lactate and there's some question in your mind, did this patient have a seizure or not? Typically the lactate will be very elevated, and then will come down immediately, within a couple of hours after their seizure. So it can be a really helpful test when it's really hard to know what exactly happened to the patient.
Phenomenal. Any other tests that we will get for this lady? Remember, when you are thinking of testing, the reason why you're getting testing is to help you with your differential. So we said she's having seizures. Now we want to know what the etiology is. So we get testing to help us figure out which of the etiologies in that vitamins mnemonic is most likely. And you get the testing to help you figure out, okay, toxic is most likely, so I want to get a UDS. I want to rule out metabolic, so I get a CB a CMP. I want to rule out infection, so I get CBC and blood cultures if she was having fevers. Or so does that make sense? So sometimes I hear medical students just randomly throwing up orders, and then I'm like, why are you getting those orders? So you get orders to help with your differential diagnosis that you have already come up with before you put in the orders. And that's, you use your differential diagnosis to guide what orders you're going to be doing. So yeah, I think this is, these are looking at our list of vitamins, these are, some of the basic orders that I would get. So now we get to imaging.
Oh, let's get also TSH then, just to.
Yeah, sure. So for the insulin, I want to get insulin. You can rule out, I would just get glucose, or point of care glucose. And if it's too low, we treat. If it's too high, we treat. So no need to really get insulin. Fantastic. Great job, everyone. So now we're going to do imaging. So what imaging orders would you put in? And let's do it from priority. We're in the ED.
If there's headache, I'm going to go ahead and CT.
Did she say she had a headache?
No.
Okay.
But there's a potential other reason to consider a head CT. What is that?
The seizure.
Or perhaps if you're wanting to do a motor puncture.
But the partner said was sitting.
She had trauma.
Trauma.
She fell.
Right. She fell and hit her head.
Was unconscious.
Right. So falling in itself doesn't necessarily require a CT, right? We have a tendency to want to CT everyone, but unless they've actually had head trauma, there's no reason to CT the head. I mean, unless you're thinking, brain tumor, which would answer the question. But I mean, in this particular case, my main reason to do it would be because apparently they have marble floors in their breakfast area. And she hit her head on a marble floor.
I have a question. I have been trying to I've been listening, and now I can fully pay attention to the case, because I was kind of in class and in Zoom. But I are we in the ER? Are we in inpatient?
ER.
Okay, because I was gonna say EEG, but I was that's not happening in the ER, so I'm taking it back.
Good jobs. Oh, you made me so proud. I love how you thought that through, because if this patient is on the inpatient service, I would definitely be thinking of a EEG if she was already admitted. But in the ED, that's not, in the ED, and I'll let the ED doc, talk more, but the job in the ED is to triage. So great job. What other? So it looks like we're all going to get a CT scan. Exactly. I would get a CT scan in her ASAP. She's having seizures. We don't know why. So in and of itself, if someone comes in with seizures, I'm getting a head CT. And to even make more of an argument for a head CT, she had the seizures and she hit her head and she's confused and she fell. So all that means I need to make sure that she's not bleeding in her brain. She doesn't have a broken skull or anything like that. So phenomenal. Head CT, great. Any other imaging?
So I'm so sorry to do this because normally I just try to leave quietly, but I actually need to get going. There's 2 points I wanted to make actually going back to history. One of the things that I don't remember if this was talked about, did we actually ask, was she, as she came out of whatever this event was she alert, oriented immediately? Was she still confused and sleepy? Again, asking about a post-ictal phase. So that was just one thing I wanted to mention. And the other thing I wanted to mention, it's important to have things like encephalitis on the differential and infections. But typically when we see encephalitis, we're going to see some level of decreased alertness prior to an event like a seizure. Typically, encephalitis does not present as a seizure. I mean, it can, of course, encephalitis can present in any way, but the more common thing is going to be some level of obtundation, and then potentially as a manifestation we're going to see we're going to see like a seizure or similar activity. So I just kind of wanted to point that out. Again, I'm not saying that it's wrong to have it on the differential. It's important to keep on the differential because patients can fool us, and encephalitis didn't read the textbook. So it's going to present how it's going to present. But it's just important when you're trying to judge where on the differential it's going to go as a potential etiology to understand that it's not typically going to show up as alert-oriented eating cereal and then had a seizure.
And thank you so much for being on stage and for helping. And I hope we can continue to do more of these together and help facilitate the students in their thinking and their thought process. Thank you so much.
Yeah, and if you guys ever want me to do like a pulmonary case, let me know.
Oh, that would be awesome. That would be awesome.
I don't understand anything about the water.
Me neither.
It's a dead space BQ. I'm like, good night.
Don't worry about that.
Okay, so Dr. Eseosa, why don't we? Do you want to like DM me on Insta or something, and we can arrange a date and a time?
Yeah, that'd be awesome.
Sounds good. Have fun, guys. You guys are doing awesome, by the way.
Thank you.
Thank you so much. Thank you so much.
Fantastic. Oh, so now that we would do imaging in the room. So what other imaging? And I'll let the ED doc talk more about what other imaging would we do that's outside of the neurological realm, given how she presented.
Yeah, thanks, guys. Anytime somebody falls, especially if they bonk their head, you just want to at least think about other injuries. The most commonly missed fracture is the second fracture. You see the first one, oh, they broke their hip. And then you forget to examine the rest of their body. So anybody that bonks their head, I will just ask if they're having neck pain. I will push on their C-spine and just see if they have any tenderness. We have a bunch of really good clinical decision rules that can decide if somebody needs a CT of their C-spine as well. And then just to comment on the head CT, I'll just point out that in this case, I think the best reason that we're doing a head CT is because this is a new onset seizure. Yes, it will also look to see if there's a skull fracture, if there's a subdural, anything like that. In the ED, we do not image people if they have a known seizure disorder and they bonk their head, because that's really common. And we also have really good clinical decision rules to decide who needs a head CT. So I fully agree with head CT in this woman. You could make a case that from her trauma, she may or may not need a head CT, but because this is a new onset seizure and we can get a head CT within about 3 minutes in the ED, a head CT is absolutely indicated. But I would say in the vast majority of patients that fall and bonk their head, even if they have loss of consciousness, we actually don't head CT most of those people, and we have got decision rules that help us decide that too.
That's a very interesting point that you bring up, and it goes into just differences in patient practice. So from my side, if a patient comes, even if they have a history of epilepsy and they fall and hit their head, I would get a CT head. So I guess it just really depends on, patient or physician practice and, different institutions and different specialties, but there isn't any right or wrong answer with that. So yeah, thank you for bringing that up, Dr. Walker.
I have a question. I know we kind of passed the lab section, but if we were getting if it's a new onset seizure, would we not get a lumbar puncture just to check to see if they have meningitis that was causing the seizure?
So, do you think she has meningitis?
I mean, she was way worse, but I was just
right. So yeah, so if you would get the lumbar puncture, if you are concerned for, like you brought up, for some kind of infection. So in her, she doesn't really have symptoms that are concerning for a meningitis and encephalitis type picture. So if we can figure out why she had the seizures without having to do a lumbar puncture on her, then that saves her lumbar puncture. So it's a case by case basis. So I guess what I'm trying to say is not every person that comes in with seizures needs lumbar puncture. Yeah, that's very, very good. Great question. Okay, great. Yeah. So that's so we've done the imaging. We want to get a CT head scan, and then we also want to look and see if we need to get a trauma workup that includes maybe CT imaging of the neck spine or of the C-spine and anything else that might be relevant in this case. So you guys have done a phenomenal job, and this is basically what the high yield points I wanted to help teach you all is how to approach a patient with abnormal movement, how to do it in a very systematic way, how to ask questions that are pertinent to the clinical presentation. So we did that well. And then on top of that, once you understand, kind of get the history, then coming up with a differential diagnosis for seizures. And then once you, coming up with a differential diagnosis for abnormal movement, which include seizures, include convulsive syncopal episodes, and also include pseudo seizures. And because she's in the ED, we have to rule out things that can kill her. So in that, if seizures are on your differential, then you want to start thinking about, okay, what are the etiologies of seizures? And one mnemonic I use is vitamins. There are many other mnemonics that people use, but make sure you use some kind of system that you can keep track of the etiologies of seizures, because then that will help you figure out what labs and imaging that you want to do. So with that, that is the summary. I hope you guys learned a lot. This was very fun. And I thank Dr. Walker for helping walk us through the case as well, and for the other physician that also walked us through the case. And you guys follow me on Clubhouse, because I tend to do a lot of these sessions just randomly when I have time, because I love teaching. Also follow me on YouTube, because I will be uploading my whiteboard onto the YouTube channel, so that you could go back, you can take a look at the videos, you can take notes and use this information for a patient that comes into the hospital for abnormal movements. Another thing that I'm starting to do as well is I'm trying to do this concept where we all are helping each other. So students are helping students, physicians are helping students, and we're all helping each other. And one thing that I would like to do is to start to upload notes, student notes based on these lectures. So if there's anyone in the audience who wants to send me like bullet points from this lecture, I will be offering a 15-minute one-on-one session that you can ask me any questions you want related to medicine in exchange for your notes. So that's something that I've just started today. So if anyone is interested in that, you can message me on Instagram or Facebook or any of my social media platforms and send me the notes for this lecture. And then we can set up a time for a 15-minute one-on-one free, advice on anything you need that I could help you with. So with that, does anyone have any questions, comments, suggestions?
Thanks for doing this. Yeah, if you guys want some ER cases, I'm happy to do some ER cases with you guys too.
Please. Yeah, thank you so much for having this discussion. It's been very helpful to me.
Dan?
So that came up on.
Hi, yes, I did. Thank you so much, Dr. Is it Eseosa? Sorry if I'm mispronouncing it. I joined one of your cases the other night. I was one of the medical students, and I really enjoyed it. And I don't think I will ever forget Guillain-Barré syndrome anymore. So now I know everything. It's just if you could have more sessions on cerebellar diseases or conditions, whatever it's called, or just the cerebellum, how it works, the physiology behind it, I would really appreciate it, because I know I'm struggling a lot, and I'm going to start with neurology in a bit. So if it's possible, can you have some cases or just revision rooms for that? That would be really great. Thank you so much.
Yes, of course. So cases on cortex, anything affecting the brain, like the brain cortex imaging, sure, yeah, I could definitely, I'm taking notes now. I can definitely come up with some fun cases on that topic. Any other topics? Yeah, no problem. Any other topics that people are interested in from a neurology standpoint that you would like for me to have cases on? You can always feel free to reach out to me on social media, on all the different platforms. And I hope that one of you takes me up on my offer for a free 15-minute one-on-one session about anything you need in medicine for exchange, for bullet point notes that I can put up online so that other students can have access to this information. I'm all about creating free content so that we can share with each other and help each other become better physicians so that we can take care of our patients. So thank you so much for your time. And Dr. Walker, I hope that we can do more rooms together. I'm happy to help sit in on rooms that you do from an emergency medicine standpoint, because I want to learn from you as well. So I hope we can reach out offline and get some kind of schedule going together.
Yeah, super fun. Thanks, everybody.
Thank you, everyone. Enjoy the rest of your morning, afternoon, night. I will see you guys in the next room.
Thanks so much.
Thank you so much.
Dr. Eseosa?
Yeah.
If you're going to follow me later, I can pin you to another clinic with rounds. You can then share about your YouTube channel and all that. That'd be great.
Oh, sure. Yeah. Thank you.
Awesome. All right, then take care.
Thank you. You too.